So the title of my lecture is a technique title, which is Porcelain Vein versus Pressure Cooker Technique in Venous Approach, Marketing or Real Concept. Why I wanted to make this lecture, it's just to show the difficulties that we have when we are treating the AVM by the venous approach, but to emphasize some tips and tricks just to show about what we are discussing in the congresses. So sometimes we speak about porcelain vein, and sometimes we speak about pressure cooker. And so this is a confusion in the head, in the mind of people. So let's start by the beginning. So from the beginning, it's clear. So what you discussed right now, what we will have to discuss in AVM treatment or cure. So whatever is the technique, what we have to cure in an AVM for the moment is the artery, the nidus, and the vein. So, Kirill, you showed a case in your series where the vein wasn't occluded and we had a remnant of the AVM. And here I can understand our colleagues who are neurosurgeons. And so when they say that in the past, we were obliged to treat an AVM, to resect an AVM once it's embolized, because you have a high risk of recanalization. I could understand this fact because in the past we were using only glue, and when we are using glue, we are afraid to go to the vein because the glue, once it arrives in the vein, it occludes the vein. And if we are afraid of that, so we never attempt the vein by the glue, and this is why in the past, the risk of recanalization, or let's say the absence of disappearance of an AVM, was very low. So this is why the neurosurgeon were going through the AVM, even if we were saying that angiographically the AVM was excluded. So clearly, nowadays, whatever is the technique, surgery, radiosurgery, or embolization, what we have to occlude completely is artery, nidus, and vein. So now let's speak a bit about the venous approach and what's the concept of the venous approach. So when we go by the venous approach, we inject the liquid inside the vein and we progress inside the nidus in order to attempt the artery. And attempting the artery is the main key point, because if we don't attempt the artery by the vein, so we have a leg somewhere in the active zone. So we call the active zone nowadays the nidus. For me, it's what we call the primary vein, but whatever. So this is those abnormal vessels that we call the nidus, where we find the active zone. And in order to be sure that we went through all this active zone and we don't have any risk of bleeding after the procedure, we have to attempt the artery coming from the vein. Now, when we inject in a tube or in the vein, the liquid agent, which is the EVO, so what happens? So the liquid goes among the wall of the vessel, and progressively by stopping and injecting and whatever, so the DMSO, which is the solvent, disappears, and progressively we reduce the size of the AVM. And here I'm coming to the porcelain vein. The porcelain vein doesn't occlude, this technique doesn't occlude the vein when we are treating from the vein. We narrow the vessel progressively and we play with the resistance in order to occlude the nidus before occluding the vein. So this is the, let's say, the demonstration of that. So once we go by what we call the porcelain vein, we put coils inside the vein just to limit the reflux over the vein when we are injecting backward. And so we are playing inside the vessel in order to exclude the AVM before occluding the vein. So here the role of the coils couldn't occlude a vein which is draining an AVM. The coils are here just to limit the leakage of the liquid when we are injecting inside the vein. So what's the difference now between the porcelain vein and the pressure cooker technique? So in the porcelain vein, when we go through the porcelain vein, so we put two catheters. As I said, the coils that we put inside are loose and they don't occlude the vein. And like this, we play with the resistance in order to feel backward the nidus before occluding the vein. So in the pressure cooker technique, so we make the same thing, but in addition to the coils, we inject glue in order to obtain a total occlusion of the vein, and like this we progress. Here there is a debate, because there is two things which are important. The first thing, once we occlude the vein, and you neurosurgeons, you know clearly what does it mean. When we occlude the vein before the nidus, we have a high risk of bleeding. So we are obliged to inject the liquid inside the nidus very, very quickly. Why? Because if we don't inject it quickly, we have a risk that the AVM will rupture. And once you inject it quickly, so you have a risk to obtain a reflux in the normal arteries. And if you obtain the reflux in the normal arteries, you have a risk of a arterial ischemia. And the arterial ischemia is much more frequent than the venous ischemia when we are going by the venous approach. So this is what we have to take care about. So this you understood. So right now that my favorite technique is not the pressure cooker, but the porcelain vein technique. So I will not say anything about about the pressure cooker technique. Probably in the session of microvention, we can have a debate with René Chapeau about that, because this is his favorite technique. But whatever, René uses this technique, so the pressure cooker one, only once the nidus is very small, and so he has to go quickly. So what's the advantage of this pressure cooker technique is to limit the reflux inside the vein. But in the porcelain vein technique till now, with 300 cases done, so we don't have, it's really very, very rare to get a venous occlusion when we respect some rules. So let's say this is the porcelain vein technique, and this is what I will debate about. And so what I asked as a question to Kirill after his session was related to this. This is a temporal AVM, a uncal AVM, so which is drained by the uncal vein here. So you can see the uncal vein, the basal vein, and the Gallian vein. And so if you look to the procedure, it's quite simple to go through this AVM. And so we put two microcatheters inside the nidus. So one microcatheter that you see distally here, and so the second microcatheter in the vein, just to put a loose packing coils, just to limit the reflux inside the AVM. And as I said previously, if we want to occlude the AVM and be sure that the AVM will not bleed after the procedure, what we have to do is to be sure that we went backward to the artery. But here, going backward to the artery which is supplying this AVM is what you can see here, which is the anterior choroidal artery. And as you know, if we have a proximal reflux to the anterior choroidal artery, we have a risk to occlude the perforators and risk of deficit for the patient. So this is why my favorite is the porcelain vein technique. So here you can see that we are injecting inside the nidus, and you can see here arriving, because we are injecting very slowly. We are not pressed by the fact that the vein is occluded or whatever. Here the vein is not occluded. We have time. So to go backward of inside the feeder, but you can see the balloon here inside the carotid artery, the internal carotid artery. You can see that we are still far from the origin of the anterior choroidal artery where the perforators arise. So clearly for me, the result that we have to get at the end of the procedure has to show us that we get backward to the artery. Here you can see the anterior choroidal artery. The perforators is beyond the ventricular point of the choroidal artery, which is here completely patent, and so the AVM is excluded and nothing is missing around. So this is the second rule that we have to get in order to avoid the bleeding of the AVM. So the fact that we don't, on the delayed angiogram, we don't have any stagnation at the level of the AVM. So now, what's the meaning of this technique? So how to avoid the reflux inside the vein, and how to provoke the feedback to the artery, so the feeling of the artery backward. So we have one technique which is really a very nice technique, which is the use of the arterial balloon. So you know that we have a flow inside the artery. So we put the coils inside. And so afterward, we bring a balloon in the artery that we put proximally. We are not too distant. And like this, we reverse the flow inside the AVM. And like this, by the aspiration on the normal arteries, we will provoke the backward, the feeding backward of the feeder, and we limit the reflux inside the vein. So this is what we are attempting. So the balloon is it's not only a way or a device to inject the liquid material, it's a device to reverse the flow and to oblige the liquid to come backward till the level of the artery. So an example, so this is a young male, a young boy who has this AVM which didn't bleed. And so let's say by surgery we can resect it, but when we go by on the vascular approach, here is he had got so the arterial injection, as Kirill said. The kissing technique. So he had got the liquid inside from the artery inside the nidus, and now we go by the vein. So we go by the vein. First of all, we put the microcatheters, we put the coils. Here we have the liquid coils that we put at this level. You can see them on the demonstration here. And after what, we bring the balloon, we inflate the balloon in the artery. You can see here we are far from the nidus. And we want that the liquid will come back inside this artery, but not too proximal. Otherwise, we will get an infraction in the territory of this artery. So we bring the balloon, we inflate the balloon, and with the distal microcatheter put inside the vein, we inject the liquid in order to obtain the reflux inside this artery. And so you can see the demonstration here. So we can see that the liquid is coming backward very slowly inside the artery because we are using this porcelain vein technique. The vein is not occluded, and we have time to inject slowly the liquid and go backward inside the artery and occlude the artery before going, without going inside the normal arteries. So this is the advantage of the porcelain vein. And so the techniques of the 4D allow us to see that all the superposition of the onyx that we injected here is feeling the whole nidus. And so this is what we are willing to get. So a total occlusion of the AVM with a reflux inside the artery. So coming from the vein, showing that we get all the nidus treated. And so as usual, as you can see on this MRI done after the procedure, that there is no venous ischemia. And it's really very, very, very rare to get a venous ischemia when we are coming from the vein. But of course, by limiting the reflux on the vein, which is draining the AVM. So how to perform it? So we looked to our series, and this is a paper which was published recently in the department. So what are let's say the characteristics of the AVM when we use the venous approach, which tell us that we have a higher risk of bleeding? And we found two things in our series. So when the nidus is larger than 3 centimeters, and when we have a multiple draining vein, so this is why for us nowadays, when we want to cure an AVM, so we have to get this nidus smaller than 3 centimeters. So by the kissing technique or by a previous embolization by the arterial side. And so once the nidus is less than 3 centimeters here, we could consider the treatment by the venous approach. So this is what, as we said, nidus as small as possible, single draining vein when we want to cure, and it's not only the considerations that we have to take care about. So I looked to the bibliography just to see what are the papers which are against the venous approach, and I found this one. So they said that the venous approach shouldn't be considered as a first-line treatment. And so this is a part of our practice nowadays. So this is a part of our strategy nowadays. And so I didn't understand this conclusion at the beginning till I looked to the case that they presented in their series. And so this is a 8-year-old boy who presented with sudden headache and vomiting, and he had got a bleeding of this AVM. And so they went through the vein directly. This is a posterior thalamic AVM, which is drained by the posterior thalamic vein here. So they put the microcatheter inside, and they used the porcelain vein technique. So they didn't put coils, because the porcelain vein technique could be done as well without coils. And they put the balloon inside the artery, so they respected the rules. And after what, they showed this B-thalamic ischemia here, and this tectal area ischemia as well. And so when I looked carefully to the images, I saw this. So you have the balloon here. They've got the reflux on the artery, but they came proximally on the diencephalic artery. So what we see here is not an ischemia. So what we see here, it's not an ischemia in the venous territory, but this is an ischemia in the arterial territory. The B-thalamic ischemia and the tectal areas ischemia are related to the fact that we didn't respect this artery, which is the middle diencephalic artery. So the question is, they had this result, so this beautiful result at the end of the procedure, but the complication was arterial, as I said previously. So clearly here, if we want to avoid this complication, here is a similar case done in the department, a patient who bled from this thalamic AVM that you can see here. So this is a thalamic AVM. You can see it here, supplied by the anterior group of the thalamic arteries from the posterior communicating artery here, and supplied by the posterior group as well. And if you look very carefully, you can see the diencephalic artery here. So the diencephalic artery is a mid one. And if we made the same procedure that they made, we had a risk to get the same complication. So this is an AVM. So for the first treatment option that we've done, so we went through this those particular, so in the first procedure that we make, we try to understand the venous system, like we can see it here. So how the AVM is drained, so that we have the inferior thalamic vein here, so which is draining the AVM, going to the basal vein on the left side, and so by the posterior communicating vein, which is the interpeduncular vein, communicating with the right side. So here we have to understand it before going through the procedure by the venous approach. But before everything, we have to go and to protect those arteries, which is the diencephalic artery. And the diencephalic artery, as all the perforators, we don't protect them by putting a balloon. We protect them by occluding them distally. And so, because if we don't do it, so we will get the same complication that our colleagues have got. So clearly the first procedure has to be going by the arterial side, occluding distally by liquid material, which is not a non-adhesive liquid material. So here we put glue inside the nidus, but our idea was not to reduce the nidus clearly. It was to protect distally the diencephalic artery. So you can see it here. After what, so we went in the second session. So in the first session, we still went through the anterior part. So here you can see that the diencephalic artery, which is still patent after the arterial approach, the AVM is still patent. We went as well by the second procedure through the vein. And so through the vein, we put two balloons, so one balloon by the anterior circulation and one balloon in the posterior circulation. Once we navigated the microcatheter here, and so this technique, we made it as a porcelain vein technique without putting coils. And so as you can see here, so the catheters are in place, the balloons are inflated, and the liquid was injected till the opacification of the feeders, which are no more the feeders by the diencephalic system. And like this, so we occluded the whole AVM. You can see here the result after the procedure, and you can see here the cast of onyx done, and you can see here that we didn't get any of the previous complication that the colleagues described. Why? Because so those perforators were protected from the beginning. So my conclusion is the porcelain vein technique is unlike the venous pressure cooker technique. So it doesn't occlude the draining vein during the venous approach for AVM treatment. And in our practice, it reduces the risk of AVM rupture and arterial ischemia during the procedure. and its risk of normal venous ischemia is rare when performed in the state of the art. Thank you very much.